right, so let's just recap. Last time that we met, we identified that the pressure continues to decline as blood travels through our systemic circuit. We also noted that blood has what type of characteristic when traveling through our arteries and arterioles? We said it is pulsatile. Very good. Pulsating is pulsatile. It means the pressure goes up, down, and we can measure a pulse in an artery or even an arterial. Had to build somebody's body. Okay? It continues to pulse until we get to the end of the arterioles, where now the blood flow is no longer pulsatile. We could say nice and constant or steady, or we could say laminar. We don't want the blood flow pulsing in our capillaries because why?
Too little. There's no elastic.
Smooth muscle, they're not elastic, right? They're not going to stretch, they're probably going to bust. If blood comes in there so fast and hard. Without really thinking about it, you might presume that capillaries must have the least pressure. Is that true?
Yes.
No. Is it true that capillaries have the least amount of blood pressure? It's not true. Our veins do, because we need to maintain a gradient. So if the pressure was the least in the capillaries, the blood would just stop flowing at the capillaries. And we don't want that, right? To load into the veins, first the venules, then into the veins. What does fluctuate like that? Big, small, big, about our blood vessels. What does fluctuate? Not the pressure, but the between all of our blood vessels, what does fluctuate? The size can, the diameter can change. It is different between all of our vessels. The what? The length of the vessels should hopefully be constant. I'm gonna help you guys. Yeah, some of you guys are, the things that you're identifying are some are correct. But we identified, if you remember, in our blood vessels, because of their diameter and etc., the velocity and because of the surface area of the vessels. If you remember, the velocity, the speed is greatest in our arteries, least in our, the speed of blood flow is least in our capillaries, and then picks up again by the time we get to the venules and the veins. We saw that looking at figure 14-15. Maybe I'll choose this chart. We showed the inverse relationship between the cross-sectional area and the velocity. So the velocity does bottom out at the capillaries, but does the pressure bottom out at the capillaries? No, it continues to decline throughout the system. Is that okay? Acceptable? So we went through and identified this pressure does decline through our system. And then we left off looking about the resistance to the flow of blood. And we at least introduced them. Last time we talked about viscosity, right? That means the thickness or the stickiness of the blood. We said, of course, that will change throughout your life and even maybe between days or something like that. But from moment to moment, it's not going to fluctuate significantly. And so it's a constant factor to the opposition of flow of blood that your body's just kind of accounting for. Okay? Another constant that your body's continuously accounting for is the blood vessel length. Once in adulthood, your blood vessels are pretty well formed. You're not going to, for most people, you're not going to see some random growth, like maybe in some diseases or something like that, or pregnancy, but those are kind of the exceptions, not the norm. So your blood vessels maintain a standard length, and so your body also accounts for that given length of blood vessels that blood has to kind of drag against or flow through. Of the resistance factors, something can change from moment to moment, and that's the diameter of our, particularly our arterioles, but certainly we know that arteries and somewhat the veins as well can change diameter pretty quickly. And if we quickly change the diameter of a blood vessel, we quickly and profoundly change the resistance. And so this PR stands for peripheral resistance. A slight change in the peripheral resistance or blood vessel diameter has a major indication of where blood is going to go or where it will not go. And so what we concluded is how this diameter is changed is by the blood vessels either constricting or dilating. And we went through this, didn't we? Yes. Very good. So if we look at the three scenarios, we can see an arterial under what's considered to be resting conditions. We can see the smooth musculature, we can see the diameter of the lumen where the blood flow would travel through. However, if a downstream organ doesn't need as much blood flow, say that's the arterial going to your skeletal muscles and you're sitting in class, you're not using them, the muscles in your legs, right? So we don't need to blast those skeletal muscles with excessive blood flow. And so the arterioles going up to your skeletal muscles will do what? Constrict, and that causes our resistance to go up, and the blood flow downstream would be less, significantly and fast. It's a quick little reflex. Conversely, if you were to get up and go to physiology, and I say go run for 20 minutes, and after the anger gets over, what's going to happen? Your blood vessels are going, and your skeletal muscles are going to dilate if you go through the exercise, right? And the resistance has gone down, yet the blood flow to that downstream organ has gone up. So just a way to change the blood flow to one spot of the body to another, just vasoconstrict or vasodilate the arterioles to those particular organs. Is that concept? Okay. So the term you would use is vasodilation. The vaso referring to the vessels, the dilation relaxing the opening of the diameter, and the constriction the muscles would contract. In figure 14.12 is taking the same concept that we just illustrated and just showing those downstream tissues, right? So this is going to be a repetition, but kind of putting into perspective when we change the blood flow, right, what's going on. So this is an arterial, a single arterial, going to some tissue. So that could be, again, your skeletal muscle cells, your brain or your liver, whatever. Pick whatever part of the body. And we know that the point of the circulatory system is to bring not only our respiratory gases, but nutrients and hormones and fluids, electrolytes, etc., to the tissues. And so when a cell is under resting or labeled here normal status, the delivery of oxygen with the pickup of carbon dioxide and fill in the blank, everything else is matched. Okay? So we're in homeostasis, right? However, if those tissues become more metabolically active, so let's say this is your brain cells, and you come in and take your test, right? You're going to start using those cells a little bit more, and they're going to need more oxygen and be giving off more CO2, and they're going to be needing all kinds of other stuff, right? Glucose and etc. So they become more metabolically active. They need more oxygen, but the blood flow is giving them just enough as if they were at rest. So actually their oxygen levels would become what? If I need more, but my blood flow is now low, my oxygen levels being delivered are also low. But my carbon dioxide levels would begin to raise and increase and elevate. So now, if we don't fix this, the cell will quickly begin to fall out of homeostasis. We don't want that, right? So let's fix it really quickly. What did this vessel do? Dilate. Once it dilates, we increase the blood flow, pick up that excessive carbon dioxide, and then drop off the right amount of oxygen to meet the demands of that tissue. And once that happens, we're back at homeostasis set point. So this resistance of the arterioles really dictates the downstream flow that serves the organs and the tissues. Any questions about that concept? We're going to do the same thing in the flow chart, figure 1414, to illustrate how this can be monitored just locally. It's called the myogenic. What does myo mean? Muscle. Okay, so it's a stretch response. And so, if we're looking at our arterial, go into some tissue, the blood pressure goes up, so does the flow into that tissue. If the blood flow increases, those blood vessels will, I want to change your word a little bit. They're going to stretch. And technically they are. You could be okay with that term. They're going to stretch out, but just like if you were to put water in a balloon, the balloon would stretch. If you put a little bit more blood in a vessel, it's going to stretch out a little bit. That stretching of the arterial actually tells the vessel to do what? Constrict. Right? So it stretches out so much, so the arteriole says, "Whoa, I've got to acknowledge this blood." Okay? And so it actually constricts. To squeeze on it. That changes our resistance, which changes our blood flow. To keep it in homeostasis. So what type of feedback mechanism is this? A negative feedback mechanism. My blood flow becomes so low, my vessels are now no longer stretched. What should the blood vessel do? Nothing. It should, if we turn it off too much, what should the blood vessel then do? Dilate. It just responds to that flow, blood flow pushing through it. If there's a lot of blood flow going too fast, if you will, it'll squeeze it down. And if there's not enough, it'll relax. So make sure that flow through whatever vessel is right for that vessel. So it's locally controlled. Additionally, if we look at figure 14.1, this image gives you just a nice visual snapshot of what we've actually become introduced to in chapter, I think it was 11, when we introduced the autonomic nervous system. We noted that the autonomic nervous system controls our body under rest versus fight or flight or exercise type scenarios to change things like our respiratory rate, even our renal filtration rate, blood flow to different parts of the body. So this is looking specifically at the blood flow distribution. First thing is, you can see that not all organs receive the same amount of blood flow at any given point in time. The blood flow to my eye would be different than the blood flow to the muscles in my leg, which would be different than the blood flow to my skin, for example. But under resting conditions, our cardiac output is about 5 liters per minute. Okay, that's going to be different from each person, but on average, right? Male, female, across the board. That's about how much blood you have. As you begin to exercise, we need to shunt the blood to the organs that need oxygen, need blood, waste removal, etc. So as we exercise, you should see a huge proportion of our blood flow going to where? Your muscles. They're the ones consuming the energy. So they're going to kind of take over. And you'll see, for example, the digestive system. Let's see a drop in blood flow. Does it ever get no blood flow? No. We don't want that, right? But we want to say, well, a little bit less go over here, a little bit more go over to the skeletal muscle. So this is a nice just visual graphic illustrating how the sympathetic nervous system changes our blood flow distribution. Any questions about that graphic? Do you have a question? Okay. Am I missing a number? Is it what number? 1413? What's the picture number?
Exercise 14.9. Yeah, it's on page 4 of 6.
Thank you. So my number's okay?
Thank you.
Table 14, 2 in your textbook, identifies outside of the smooth muscles just responding to stretch like we saw in the myogenic. We have obviously extrinsic controls over the arterial diameter as implied in the previous image. So certainly our sympathetic nervous system can cause some of our arterioles to constrict, which we know increases our blood pressure and our distribution resistance, etc. Epinephrine, a sympathetic neurotransmitter, it also has some constriction effects, but it also might cause some blood vessels to dilate. Again, if you remember chapter 5, we studied how one messenger can have completely different effects in different tissues, because the different tissues would have either differently built receptors or just second messenger pathways inside of them. And epinephrine was the example where we saw these all kinds of crazy different types of responses. And so our blood vessels are also responsive, or the smooth muscle in our blood vessels are also responsive to epinephrine. So for example, the smooth muscle lining the blood vessels to my stomach will probably do what? During exercise, we'll probably... during exercise, so to the muscles that say, not even look at the blood vessels, say that control my stomach for digestion, those muscles will probably
Stop.
So if I'm exercising, my stomach better relax a little bit, don't churn and etc. However, the blood vessels taking blood over to my kidneys maybe should constrict, right? To not filter blood so much at that point in time. So we just got opposing effects due to the presence of epinephrine, that second messenger. Some other hormones, which we, or at least one that we've seen before, called vasopressin. What was the other word for that? ADH, anti-diuretic hormone. Not only does it target the kidneys, we also said it targets our blood vessels and tells them to constrict, which causes our blood pressure to increase. There's another hormone I don't believe we've introduced yet this semester. It's called angiotensin II. We'll mention it today, and on the last day of class, we'll talk about it a little bit more, but it's an important part for our renal physiology. But it also causes our blood vessels to constrict to increase our blood pressure. We can then now look, so we've talked about arterioles and how they can regulate the blood flow and the pressure into the capillaries that go to a particular part of the body. I want to focus now on the capillaries because that's really where the action takes place. What happens at our capillaries?
Gas exchange.
Gas exchange. What else? You could bulk flow. We're going to exchange gases, nutrients, hormones, you name it. If it's going to get exchanged, it's going to happen across some capillary cell in someone's body. And if we look at the capillaries, there are two major categories of capillaries. One is called continuous, and the other called fenestrated. In the continuous capillaries, the cells that comprise the capillary, if you remember we talked about membrane junctions way back in chapter 4 maybe. The membrane junctions are a little bit more prominent. I'm going to be careful using that word. Let me re-say it this way. The membranes are joined a bit more closely. The cell membranes are joined more closely than when compared to the fenestrated capillaries. So that between the individual cells, the cells are not so tightly bound together that there are little spaces between them or gaps between them. Because what do we need to move through here?
All our gases.
Gases, chemicals, hormones, whatever. We need to have the ability to transfer or filter plasma to the interstitial fluid and reabsorb interstitial fluid back into the capillaries. And so to enhance that, the capillaries have these little pores between them. But they're much smaller in what's called the continuous capillaries. Here it's described as an intercellular gap. The term pore that I use is more useful to describe the next type, the fenestrated capillaries. But can you see the space? This is where my hand is. This is one cell, and this is another cell. So there's a little inter means between cellular, a gap between the cells.
And that's continuous, right?
This is the continuous, yes. But there still is an intercellular gap. It's much smaller compared to what we're about to study. We're to compare the continuous to the fenestrated capillaries. Between the little pores, or the fenestration, you'll find these little pores. So these little cells, you'll find the pores are present, but you may notice that they're a bit larger in representation. So not only can we filter and reabsorb here, but it's a lot easier to filter and reabsorb. And the holes, the gaps, or the pores are big enough that entire other cells, like your immune cells, can be transferred between blood plasma and the interstitial fluid. Can you see that discernible difference?
You said immune cells can transfer between that.
So the gaps are so big that not only just like little molecules like glucose or whatever can get in and out, but entire other cells can, you wouldn't use the word filter or reabsorb. It's called transcytosis, not transcytosis, but I will think of it later. There's a different, you wouldn't say the white blood cells are filtered out. They actually voluntarily go through. So what I was acknowledging is the polars are big enough that an entire cell can move from one location to another. Did that answer your question? Yes.
So the difference is the amount of things that pass through
The size.
the size.
The size of the particles. I'm sorry?
The size of the gap.
The size of the gaps. Okay, so the bigger the gap, the bigger the particle that could move from one spot to another. Did that answer your question? What we're going to do now is look at how something, whatever, moves from the plasma to the interstitial fluid and vice versa. To do that, though, we need a gradient.
What,
Good job. Yes.
where are those found versus the other ones?
These are going to be more common. The continuous ones, you're going to be find, for example, in your brain, where you don't want to have so leaky randomness. The actual distribution, I can't tell you where there's more or less. But you'll.
Fenestrated ones are on the kidneys, intestines, and
Okay, kidneys, intestines, and endocrine cells as well. And the continuous brain, and kind of everything else. We will see, thank you, we will see these fenestrations on the last day when we'll look at the renal system and the glomerular capillaries. So they're definitely there too. So what we want to do is we know we need a gradient. If I want to filter plasma out or absorb interstitial fluid. We also need to call into our data bank solubility. Right? Chapter 5 information. What were our two categories of solubility? We said something is probably more hydrophilic or lipophilic. Okay. Lipophilic particles can do what across the membrane? Simply diffuse. Hydrophilic molecules, you're going to active transport them or put them through a channel or facilitate them or something like that. So all that is going to go into play. This should be kind of a review, if you will, for the transport of particles. So before we look at what's going on, let's just keep a generic pressure. Let's say pressure is higher. If I want to filter, where should the pressure be the greatest?
When you're going,
On the inside of it?
coming from
On the inside. Very good.
the inside.
So if I want to filter something from the blood plasma out in the interstitial fluid, my blood pressure, I'm just going to, my fluid pressure here should be higher than it is over here. So I have a pressure gradient. I'm just going to use our generic Lipton gradient that we introduced at the beginning of the semester. If the pressure is higher in the blood plasma than it is in the interstitial fluid, what process? What happened?
Filtration.
Filtration. Now, we're saying, well, then if we're filtering something, and if not all things are small and lipid soluble, how do they get across? Well, if things are small and lipid soluble, you know, like these little guys right here, like your gases, like oxygen, carbon dioxide, etc. How do they get here? You said they will just diffuse, and we'll say simply diffuse. Okay, so simple diffusion. But they diffuse across, they may diffuse from the plasma and across the cell membrane of my capillary cells. So across this bilayer, into the cell, across this bilayer, and out into the interstitial fluid. So these little things are cells of the capillary. Make sense? Your hormones, right? Your steroids. Estrogen, testosterone, cortisol, aldosterone, all those would just diffuse. It could diffuse across the capillary cells. Down there, there you go. Other things that are small but more hydrophilic, can they simply diffuse across a cell? But they could simply diffuse where? Through a pore. So one of these little cellular gaps. They could still just diffuse, and it would be simple diffusion, but through a pore.
Oh, that's why they're blue.
Yeah, to represent where the fluid is.
You said those are hydrophilic, right?
Are hydrophilic, are water soluble. Things like good old friend sodium, potassium, calcium, right? Glucose. They can't go through the cell, but they could go between cells. So small lipid soluble can diffuse across the cells. Water soluble particles, small water soluble particles could diffuse through the intercellular pores. What about our proteins that are still water soluble but maybe just so big that they couldn't fit through the little pore? Can we get proteins out of our blood into our cells?
Better.
Well, we need some proteins. And so how can we move a protein? We carry them. Okay. And since we're trying to carry them across the cell, what do we have to do to them?
Give them some,
Put them in a vesicle. You would endocytose them, traffic them, exocytose them. And the collective word we said was transcytosis. So we'll just wrap them in a vesicle, take them in from the capillary cell, wrap them in a vesicle, ship them right across. So it's just like a ferry, if you will, a little membrane ferry.
And those are what again?
That would be some, not all proteins, but some proteins that have some type of receptor or whatever that that cell knows to take them across. But can all proteins exit the plasma? No. So those proteins that are too big and don't have a form of transcytosis will stay where? In the plasma. It's kind of shown here, like, rejected. Right? I don't have a transporter for you, you stay in the plasma.
Now, is that is that temporarily, or they stay in there?
They'll stay in there. There's some proteins, like, have you heard of albumin, for example? You have it in your blood, it's a giant protein, and it's never going to get albumin.
Yeah.
You'll never see it under normal conditions, as far as I know, out in the interstitial fluid or in the blood plasma.
So that's by design, that rejection of them
Yes.
coming out.
Something else that does not get filtered out are your giant red blood cells. So maybe you want to draw a big old giant red blood cell in the background. And your red blood cells are almost as big as or pretty well as big as the entire lumen of the capillary, so you could just have your background. Hard to draw this little. So it would stay in there. So we don't filter out our red blood cells, right? What would happen if we filtered our blood cells? There's some bleeding going on.
We would turn different colors, right?
Pretty much run out. You would be a big bruise, basically. Like that. So your red blood cells, your red blood cells need to stay in the blood vessels. Hopefully, that's the design. If we filter out, though, fluid just went here. So what happens to the pressure? It drops, and it doesn't quite reverse, but it flip-flops. So once we push substances out, our pressure will then reverse and become so that it's more, where?
Outside.
In the interstitial fluid than in the plasma. So what happens after filtration? Reabsorption or absorption. So after that, the pressure gradient should switch. Not 100% flip-flop, but enough that you have more. I say reabsorption, but absorption is okay. And the same mechanics apply. Lipid-soluble particles simply diffuse in. Hydrophilic small particles diffuse through the intercellular spaces. Some proteins can be transcytosed. That's it.
So is it the diastole that causes? What makes it flip flop?
It's just.
No, it can't be the diastole. I'm sorry.
No, that's a good question. What happens is, and maybe I gave this example yesterday. I don't know if it helped or not. I'll let you guys tell me. Let's think of us as being fluid together in a blood vessel. Okay. All right. So y'all are in the plasma. Okay. And I'm over here. These are our capillary cells. Okay. And I'm over here. Where am I? I'm in the interstitial fluid. If we wanted to reach pressure equilibrium, about how many of you guys need to come over here? About half of us. But the force is enough that you may push, right, where more than half of you guys come. You don't have enough room to do that, but just visually, right, all you guys are pushing over here. And now what happens? Now it's greater over here, but we're still kind of moving. And so if we had more tables, some of you guys would have to go back over there to the little interstitial, right, gaps. Okay? So it's just physically taking an enclosed volume, moving it from here, and then the pressure changes, and then it moves back. And so when you see it moving outward more, we say the products are being filtered. And then when we reverse it, we say the products are being absorbed. And so it's just physically, there's only so much fluid in your body, and we just change its location where there's more of it, pressure increases, where there's less of it, it drops a little bit. Did that help a little bit?
No, it helps a lot. Is there a name for that whole process?
It's called, Brandy, you had it sort of called? Bulk flow.
Well,
Bulk flow.
everyone involved in it.
This image I have straight from your textbook, so I didn't get a chance to crop it and etc. So I want you to hone your attention here in this lower left-hand panel that I have for you in your guided notes. And this will hopefully address the questions that we just tried to illustrate that parents have. It's like, well, how does that happen? How do we know to filter? How do we know to reabsorb? Well, your vessels don't know anything, but they respond to pressure changes. And so we have a simplified arterial, capillary bed, and venule. And you've got to remember, these pictures are static, but your blood should be constantly what? Moving, flowing. It's like traffic on the highway. It's moving, right? Stuff's getting in, stuff's getting out. It's constant flowing, okay? And so imagine blood flowing constantly through an arterial, away from the heart, and then branches to a capillary. So our fluid pressure is pretty elevated. More in the capillary than it is in the interstitial fluid. So we said we're going to have more of which process? Filtration. Okay. And quantitatively, right, the pressure is about 38 millimeters of mercury. Right. So my fancy animation, you'll see some product filtering out. Okay, we have more outward pushing. Okay. However, right, we flip-flopped everybody in the room in that scenario, right? And now we're going to have the pressure higher in the interstitial fluid. So next process is absorption. The pressure, as I mentioned, is not exactly the same amount. Okay, so we're moving stuff around, but it's still higher outside the capillary than it is inside, so we have more absorption going on. As blood is flowing through, we're still filtering, we're still absorbing. Question that was asked yesterday is, well, is it like, where does this one stop, where's the other? And they both happen simultaneous. At any given point in a vessel, there may be filtration going on, there may be a reabsorption going on. But as blood enters the capillary, there's going to be a higher proportion of which process? Filtration. And as blood exits the capillary, there's going to be a higher proportion of reabsorption, even though there might be a little bit of filtration going on. Does that make sense? Just flowing, flowing, flowing. Change. Think about a big highway on and off ramps, just constant. What questions do you have about the concept of bulk flow and the general pressure gradients that drive more filtration versus absorption?
Are we going to need to know these exact pressures?
No, not for this. No. Because that'll change in different vessels throughout the body, and it's very different in, say, your kidneys, for example. But the concepts are what's important here. Where we will know pressures is like we did in your handout for specific gases for the respiratory system. We'll hit on Monday.
So Starling's theory thing, it's in the book. That familiarized me with this whole.
Yes, I gave you the super condensed version of the Starling forces. Clip notes.
So you said when blood enters the capillary, it's filtration.
There's more filtration.
More.
There may be some reabsorption going on, but not near the magnitude like you would see filtration going on. Additional clarification? We need to have a good wrap on this because this is what we're going to study on the last day of class of the kidneys. So the kidneys is basically put in practice capillary action, arterial diameter, etc. So we've talked about arteries, we've talked about arterioles, we've talked about capillaries, and then blood then drains into venules and then into veins. And if you recall, the blood pressure is continuing to drop. Even though the velocity is increasing in our veins, the blood pressure is low. And we're designed to stand upright. And so if the blood pressure is so low in our veins, if we didn't have any mechanics to get our blood, our venous blood back, our blood would pool, like collect at our legs and our feet and then etc. And so our body has a couple of what's called pumps. You might want to put like the pretend like Eric Fittler sarcastic pump, right? So it's not like a heart or something like that. But one of the things is called the skeletal muscle pump. And I'm going to give you two, so I don't know if you want to break your line into half or whatever in this spot. But I'm going to give you another one as well. I didn't see an image in your textbook. But the first is called the skeletal muscle pump. And if you recall, and when we talked about skeletal muscles chapter 12, they said that when skeletal muscles contract, they squeeze on their blood flow. And we looked at it specifically at our arteries and the kind of hindrance of the delay of oxygen. But also in your muscles are your veins. So when we squeeze on the veins, because of the presence of the valves, the blood in your veins gets propelled right away. They can only go out in one direction. It won't go backwards. So just moving will help get venous blood out of that organ and back to the heart. And it's called the skeletal muscle pump. It just squeezes right on the vein and pushes blood back towards the heart. You've been maybe more familiar with this if you work in the hospital or a clinical setting, right? And you have patients, right? If they're sedentary or immobilized or whatever, what do you need to do?
For this ambulator, for essential, what is it called? Sequential compression device?
Okay, I never knew what it's called.
Yeah, it's just like they move your, well, you put them on your calves, and they just basically pump air in and out and switch legs, and
They compress on the legs to mimic what?
walk.
Walking. Okay, so it squeezes on the veins.
My grandma has that. She has diabetes, so they're like boot things I think she has, and I guess they just help with her blood flow in the feet.
Because diabetic blood is really viscous. Do what?
They don't want patients getting like blood clots, and it helps with circulation.
It helps with circulation, distribution, clearance of toxic particles, or not even just toxic, but just things that your body normally needs to clear. So you can put them on those. If you're in physical therapy, you might massage the patient, or if they're able to walk, just tell them to get up and walk or whatever. So movement is a great way to return your blood back to the heart, just for overall health. And
That's why when you're on an airplane, they kind of do these different things.
right. So, for example, when you're on the airplane, when you're sitting stationary, you're really kind of mobilized, and your blood flow is reduced quite a bit. So it's good to get up and walk, or wiggle your feet, or something like that. So that's exactly right. You're more prone to like a clot, and then once you mobilize, when you move, that moves the clot into the circulatory system. Like you're about to move. The second pump that helps return venous blood is called the respiratory pump. Respiratory pump. Having to do with breathing, respiration, the lungs. Do you recall, hopefully last week, when we introduced the respiratory system, when you breathe in and out, we change the volume, which changes the pressure. And so when you breathe in and out, there are pressure differences between your thoracic cavity and your abdominal cavity. And so when you take a breath in, the pressure drops in the lungs and increases in the abdominal cavity. And then that high pressure in the abdominal cavity squeezes on the veins in the abdominal cavity, and it helps push also that blood back to the heart. But then when the pressure drops in the abdominal cavity, will our blood go backwards? Because we have valves in our veins. So moving returns blood, and also just breathing, that helps return blood. Venous blood back to the heart.
I'm actually kind of wondering, because I kept thinking there's no way your blood would get back to your heart just because of the valves.
Right, just the valves alone aren't gonna be enough. Yeah, you're gonna run out at some point. So it's gotta move and breathe and
Yeah.
get around. Any questions about these two pumps that help return venous blood back to the heart? All right, so it looks at, we've kind of walked through each of our vessels. We now need to introduce another type of vessels which we've not talked about yet. They are called the lymphatics. Have you heard of those before?
Yeah.
You may have heard of lymph or a lymph node. Lymphatics are a type of vessels, but they don't carry blood. What do they carry?
Lymph.
Lymph, and it is like fluid tissue. What else would you say, Brandy? Yeah. And so we wouldn't call it blood plasma. We wouldn't call it interstitial fluid. It's specifically lymph when something is trapped in the lymphatic vessels. They only do which process?
Bathe.
Bathe?
No, I heard they bathe all the cells.
Oh, okay, the fluid around you. You get the inner. Okay. What about the lymphatic vessels? What do they do? What is their job?
Move it to.
Absorb. They absorb. Okay, and they absorb substances and then put it into to make lymph. So your lymphatic vessels only absorb. What can they absorb? Where's the fluid coming from? Not the blood. Where's it coming from? Where do we see it here? Our interstitial, right? So it's right next to our capillary. So what it does is absorb interstitial fluid. Like our capillaries, but the lymph vessels can pick up bigger substances. So like those big proteins, big fat globules from your diet. Pathogens. So lymphatic vessels absorb, they do not filter the way that they're designed. They overlap, and pressure and increasing interstitial fluid can push interstitial fluid into them. But once that pressure gradient reverses, the cells overlap. There's no way that they would normally healthfully filter. Okay? So they trap. The fluid, the lymph, will go through different nodes. Does anybody know what's waiting around in the lymph nodes?
Your macrophages.
So your macrophages and some other immune cells. So I kind of refer to this as like a check station. If the pathogen is in the blood, it'll be hopefully recognized by the cells ready to go at the lymph node. And so your body will get rid of a pathogen before you may even ever get sick. Giving you function.
So these are separate, do you call them veins? What are they?
I call them lymphatic vessels. I don't know if vein,
Okay, yeah,
I would
you're
think would be more reserved for
Yes.
a vein that carries blood plasma. I do see the term capillary here though. I don't know how common that is used. But they absorb only the interstitial fluid to form what's now would then be called the plasma, or not the plasma, sorry, to form the lymph, and the lymph goes through the lymphatic nodes. You may have felt those before if you ever get sick. You ever felt those in your neck or different parts of your body? Those are lymphatic. The swellings in your neck, those are lymphatic vessels mounting an immune response when you feel those. But look where the lymphatic vessels drain. Where do they drain to? Into the veins. Into the veins. So the lymphatic contents, your lymph, gets dumped right back into the veins, right back at the vena cava, right in the heart, basically.
So they still filter, but they just do it somewhere else.
They don't filter. They only
Drains. Drain. Well, no,
they absorb. They don't filter. Okay, they don't filter the way that we have defined filtration. Pressure pushing something across. They checkpoint, if you will, the nodes But I wouldn't use the word filtration to describe what's happening in the nodes. Is that what you're talking about in the nodes? What's going on?
No, in the, when it dumps back in, it does everything,
just-
it's brought, it's absorbed back into the blood.
It's just dumped like, it's,
Like creamer and coffee.
yeah, they're just poured right in together in the same spot. There's no filtration. There's no membrane separating the lymphatic from now the blood. So there is no filtration when it goes into the circulatory system, which makes what?
So is it a drainage system?
Kind of like a drainage system. I like that.
But they get oxygen.
If it's there, sure.
I mean, it looks like they go to the pulmonary.
They pick up everywhere. They're not picking up oxygen. What are they picking up?
Oh, I.
Interstitial fluid.
Okay, I got the wrong impression.
They're there to pick up interstitial fluid, like a drainage ditch. And then, if it were the drainage ditch though, it will go back to your house or back to the city system and just dump it in. But hopefully they picked up the debris before I got put back.
So picking up the debris and dropping it back into the bank, even the debris and like pathogens and stuff?
And hopefully the pathogens get picked up along the way and cleared out by your white blood cells. And so any kind of attack would happen in the nodes. And the lymph would just continue through. To help illustrate this is your lymphatic vessels are in your digestive system throughout the body. And they are in the digestive system. And so your big fat globules from your diet, like my creamer and my coffee, even though the fat is lipid soluble, the big globs are too big to be reabsorbed into my capillaries. So my lymphatic vessels are like, come on, I got plenty of room, right? So you big fat globs from your diet go right into your lymphatic vessels and right into your veins, right throughout your whole body. All right, question far back? Heather?
Oh, I just had a random question. I see like a lot of patients who, they like leak fluid from their like lower extremities, and I just didn't know if it was like the lymph having trouble going back into the veins, or what usually causes
If the,
that. Is it just edema related?
It's probably just edema related. It could be lymphatic.
So there is lymphedema.
You can have both going on.
Because I know like a lot of times like the skin looks really like thin, the epidermis looks really, really
It's
thin.
just thin and red and just tissue looks like inflamed, I guess. A lot of times.
Probably lymphatic.
I don't know. If it's clear, possibly. If it's like perfectly clear, if it's yellow, probably not.
Sometimes I see.
Kind of both. Scott, you had a question?
Okay, yeah. So it picks up, the lymph node pick up, or the lymph picks up macromolecules too?
It can pick up macromolecules, big fat globules, big proteins that might be too big to fit through the intercellular pores in your capillaries. So this is how we can return big substances into the circulatory system. I feel like I was going to tell you something. It's pretty cool. It's part of our immune system. So if you take immunology, you'll study all the white blood cell and all those responses that we won't have a chance for that. All right. So lymphatic vessels are another type of way to reclaim our interstitial fluid and dump it back into our circulatory system. We're now going to talk about the regulation of our blood pressure. If you recall, we have the ability to measure our systolic and our diastolic blood pressure and calculate our mean arterial pressure for that gradient, for the distribution of our blood. But just like everything else we've learned this semester, we want to control it. Two big categories. How? Short-term and long-term. Which system? Short-term would be mine. Say it louder. Okay, or just nervous system, okay? And then long-term, my endocrine system, okay? So don't brain dump on me right now, okay? They're going to do that on me? Yesterday it spazzed a little bit, so don't do that, all right? So this is from our introduction, really, to be honest, chapter 1. We said if we want to extrinsically control something, our two major factors would be the nervous system. And if we want to do it long term, we're going to use the endocrine system. We also know that the nervous system is quick because we're clicking milliseconds, right? Seconds have a control, and the hormones endocrine system takes a few minutes or longer. Okay? And so likewise, our blood pressure can be maintained quickly and more long. Okay? In our quick term, right, control, we are going to affect our cardiac output by also our resistance. So we're going to target the heart and our blood vessels. Our heart will be affected by the output, and our blood vessels will change their resistance, their diameter, okay, under the nervous system. Does that make sense? We're going to go through a reflex. We're going to name the effector and etc. We just name the effectors. Okay? And we know the control center is going to be somewhere in the nervous system. Probably your brain. All right, good. All right. Long term, we're going to use hormones to change our volume. Short term changes cardiac output and resistance. Long term, we actually just change the entire volume. Add more, whatever, keep more, get rid of whatever. So if we're going to change our blood volume, we really need to target our kidneys. And that's going to be under hormonal control. You actually saw 2 hormones this semester already that target the kidneys to change our blood volume. What were they? Vasopressin or antidiuretic hormone and aldosterone. Very good. Again, the 2 hormones that we saw, the long-term regulation include aldosterone and antidiuretic hormone. We will study better that hormonal pathway when we get into the kidneys next Thursday. Okay. But first we'll look at this neural reflex. This will call into review what we learned in chapter 13 about where the sympathetic and the parasympathetic nervous system innervates the heart. So hopefully it's a bit of a, not so much a review, but just a combination of all of our chapter knowledge right here in the single little reflex arc. To understand how it works, though, we have specialized receptors. Actually, let's just review a reflex arc. We need to do a reflex arc. We need a stimulus and its particular sensory receptor, sensor nerve, afferent nerve, which communicates with a interneuron, which acts as our control center, which selects an appropriate response by selecting the appropriate efferent nerve. Is that what you said? Efferent nerve that terminates with the appropriate effector organ. So we're going to talk about our receptors, our control center, and our effectors in this reflex arc. In this reflex arc, this neural reflex arc for maintaining blood pressure, we have specialized receptors called baroreceptors. Baroreceptors monitor pressure. And they happen to be located at 2 spots where it's maybe the most important to monitor blood pressure as blood exits the heart into the aorta. So we have a baroreceptor at our aortic arch. We also have them that go up where to your neck where blood's going to go to your brain. And they're in the carotid arteries. So we have baroreceptors in the aortic arch and the carotid arteries, monitoring all the time what? Blood pressure. Always. Non-stop. Because we want to keep our blood pressure at that point. Okay with the term baroreceptor? If we're to review the reflex arc, and my the arrows are off on this image, it got bumped a little bit. We're trying to regulate our blood pressure. Our baroreceptors would talk with which integration center? What part of the brain?
Stem?
part of the brain stem called the
Oblongata.
medulla oblongata. Those cells would be acting as the interneuron. So my baroreceptors would have afferent nerves that synapse in the medulla oblongata. Medulla oblongata compares these impulses to that point. If a change is needed, it will recruit the appropriate efferent nerve to activate the appropriate effector, to bring our factor back to set point. We also know about the autonomic nervous system. We know the parasympathetic and the sympathetic nervous systems tend to oppose one another. The parasympathetic is our rest and digest. The sympathetic is the fight or flight. We also should recall from chapter 13 that the parasympathetic nervous system innervates the heart only at the SA node to change the
Heart rate.
heart rate. By contrast, the sympathetic nervous system not only innervates at the node, but also at the myocardium to change the contractility, the forcefulness. So the sympathetic nervous system can change the heart rate and contractility of the heart. They can also innervate our arterioles and some even our veins to change the
Diameter.
which changes our
No.
the word we use. Resistance is the word that we use. The resistance affected by the constriction diameter, right, whatever. So let's go through a hypothetical. Let's say I was taking a nap right now. Okay, that's purely hypothetical, right? I'm not. I'm taking a nap, and then I realize I'm supposed to be in class, and so then I hop up and I run. My blood pressure was originally low at that point. I'm asleep. Which subdivision was prevailing? Parasympathetic. I wake up scared. My baroreceptors monitor the low blood pressure, communicate to the medulla oblongata. Which nerves will be activated? Which ones? My efferent, which ones? Sympathetic. I'm going to turn on the sympathetic nerves more and slow these down a little bit so that my heart will pick up the pace and contract harder. So my cardiac output has increased. My arterioles and parts of my body will constrict to increase resistance, which increases my blood pressure. And then at some point, that high blood pressure will be detected by our baroreceptors, which communicate with the medulla oblongata, which would turn down the sympathetic activity and turn up the parasympathetic to bring me back to set point. We'll conclude class here, and then on Tuesday we'll quickly summarize chapter 15. Please read it over the weekend. Again, I might give you a heads up last week. Don't focus so much on the different types of white blood cells. They're important, but we won't talk about them. I want you to focus on the red blood cells. And then chapters 16 and 17, respiratory system crash course on Tuesday. It's imperative that you read ahead, but Tuesday's not scary. Go ahead and hand in your handout 11. Handout 12. If you want a copy, come by in my office in about 10 minutes. It is available as well in D12, but I'll print out hard copies for you guys. Sorry about that.